Welcome everyone to today's event from the Supercoda. My name is Mac and I'll be your conference operator for today's webinar on Learn the Ins and Outs of the 2019 Medicare Physician Fee Schedule Final Rule. I would like to introduce your speaker for today, Nikki Taylor. Nikki is a content specialist for the Coding Institute, where she develops content for supercoda.com. She recently transitioned from her role as the lead auditor, where she completed audits for several clients, including large and small group practices, specialty clinics, and hospitals. Nikki has more than a decade of experience in multi-specialty coding, auditing, billing, and practice management. She left the physician practice world for her current role with TCI. Nikki holds a Bachelor of Science in Healthcare Management from Mount Olive University in Mount Olive, North Carolina, and a master's degree in business administration with a concentration in healthcare management from St. Leo University in St. Leo, Florida. She obtained her certified professional coder certification, certified outpatient coder certification, certified professional medical auditor certification, certified risk adjustment coder certification, and AAPC fellowship designation from AAPC. Ms. Nikki, welcome to the webinar. We are now ready to begin.
Thanks, Mac, and hello, everyone, and welcome to today's webinar. On November 1st of 2018, the Centers for Medicare and Medicaid Services issued a final rule that includes updates to payment policies, payment rates, and quality provisions for services furnished under the Medicare Physician Fee Schedule or on or after January 1st of 2019. The calendar year 2019 Physician Fee Schedule Final Rule is one of several final rules that reflect a broader administration-wide strategy to create a healthcare system that results in better accessibility, quality, affordability, empowerment, and innovation. During today's webinar, you'll be able to take charge and learn how CMS is helping to reduce administrative burden on medical providers with their Patients Over Paperwork initiative. You'll learn the requirements for medical decision-making for home visits, gain helpful insight into documentation changes for EM visits. You'll get the inside scoop on how reimbursement may change for the future. We'll nail down changes to virtual care, including virtual check-ins, and then I'll highlight some helpful tools and resources to help you keep track of all the changes. So let's go ahead and get started. So here you can see the timeline to the final rule. The proposed rule was issued on July 12th, 2018, with a public comment period through September 10th of 2018. The final rule was published on November 1st, and then the final rule became effective on January 1st of 2019. According to the 2018 New England Journal of Medicine Catalyst Report, nearly 85% of surveyed clinicians, physicians, clinical leaders reported that physician burnout was a serious or major problem within their healthcare organization. Now, there was a slight decline from 2016 when 96% surveyed reported physician burnout, but the problem does still remain an issue, although there's been some slight decline. Physician burnout not only affects the physician or healthcare provider, but also the practice or organization, and most of all, the patients that are being treated. Some physicians have reduced their working hours, switched to administrative roles, or have left healthcare altogether due to a feeling of burnout. All of these actions cost money in having to replace providers and cost us in a loss in good healthcare providers and essentially removes providers from their first loves, which is treating patients. The main contributing factors leading to physician burnout are the documentation requirements and EHR technology. Physicians often feel that administrative burden takes them away from being able to spend meaningful time with their patients. The Patients Over Paperwork initiative focuses on reducing administrative burden while improving care coordination, health outcomes, and patients' ability to make decisions about their own care. Physicians continue to struggle with excessive regulatory requirements and unnecessary paperwork that steal time from their patient care. The proposed changes to the physician fee schedule addresses those problems head-on by proposing to streamline documentation requirements to focus on patient care and proposing to modernize payment policies so seniors and others covered by Medicare can take advantage of the latest technology to get the quality care that they need. As a part of the final rule, the Centers for Medicare and Medicaid Services announced that it will eliminate some home visit documentation requirements. Reimbursement rates for EM visits in the home billed with CPT codes 99341 through 99350 are higher than those for the equivalent office-based visits. Prior to January 1st, documentation requirements for home visits needed to include justification of the medical necessity of a home visit instead of a less expensive office or outpatient visit. As part of the ongoing effort to lessen providers' administrative burden when documenting EM service, CMS dropped this requirement. Commenters during the open comment period supported the move, suggesting that whether a visit occurs in the home or the office is best determined by the practitioner and the patient without applying additional rules. CMS agrees and finalized the policy to remove the requirement that the medical record must document the medical necessity of furnishing the visit in the home rather than in the office. So if you take at the 2019 fee schedule for office versus home visits, you can see in the second column that the home visits are reimbursed at higher rates than office visits within the same level. So for example, home visits, a new home visit CPT code 99342, which requires an expanded problem-focused history and exam and a low medical decision-making, has an allowed amount of 8109, and its equivalent 99202, which is the level 2 new patient office visit, has an allowed amount of 7748. So as you can see that the home visits are reimbursed at slightly higher rates than office visits. So moving on to medical record documentation and patient care. So clear and concise medical record documentation is essential to providing patients with quality care and is necessary for physicians and others to receive accurate and timely payments for furnished services. Medical records chronologically report the care that a patient received and records pertinent facts, findings, and observations about the patient's health history. Medical record documentation helps physicians and other healthcare professionals evaluate and plan the patient's immediate treatment and monitor the patient's health care over time. Many complain that notes written to comply with coding requirements do not support patient care and keeps doctors away from their patients. Physicians and other practitioners paid under the physician fee schedule bill for outpatient EM visits using a set of CPT codes that differentiate visits based on the level of complexity, site of service, and whether the patient is new or established. So as we know, the three key components that are taken into consideration when selecting the appropriate code to bill are the history, physical examination, and the medical decision-making. For visits that consist predominantly of counseling and/or coordination of care, time in conjunction with medical decision-making can be used as the main factor for determining an EM level. And there are currently 5 levels of EM office outpatient visits reported with CPT codes 99201 through 99215, and the reimbursement increases with each level. For coding and billing the physician fee schedule, practitioners may still use either 1995 or 1997 EM documentation guidelines. Now, these are very similar to a parallel set of guidelines present in the CPT codebook. These guidelines specify medical record information within each of the three components that serve as the supporting documentation for billing a given level of service. Stakeholders have said that the EM documentation guidelines and the code set itself are clinically outdated and may not reflect the most clinically significant or appropriate differences in patient complexity and care. Also, the guidelines may not reflect the changes in technology or the way that the electronic medical record has changed documentation and the patient's medical record. According to stakeholders, some aspects of required documentation are redundant. Current documentation guidelines may not account for changes in care delivery, such as a growing emphasis on team-based care, increases in the number of recognized chronic conditions, or increased emphasis on access to behavioral health care. So for 2019 and beyond, CMS finalized the following optional but broadly supported documentation changes for EM visits that do not require changes to coding or payment. The 2019 final rule did demonstrate CMS's growing commitment to reduce the burden of documenting EM encounters. So beginning January 1st, you and your provider will no longer have to redocument history and exam elements, such as review of a specified number of systems and family social history, if the information is already present in the medical record. But the practitioner does need to review that information, make any necessary updates, and then indicate that work in their medical record. Physicians will no longer need to duplicate notations that may have previously been included in medical records by residents or other members of the medical team for EM visits furnished by teaching physicians. Note that continuing current documentation practices is okay too. That gives you time to learn the changes, train everyone involved, and adjust the workflow. Additionally, CMS has clarified that for the chief complaint and history for new and established patient office outpatient visits, practitioners need not re-enter the medical record information that has already been entered by ancillary staff or the beneficiary. Again, the practitioner may simply indicate in the medical record that he or she reviewed and verified the information. So beginning in calendar year 2021, CMS will implement payment, coding, and additional documentation changes for EM office outpatient visits, specifically single rates for levels 2 through 4 for established and new patients, maintaining the payment rates for EM office outpatient visit level 5 in order to better account for the care and needs of complex patients. Add-on codes for level 2 through 4 visits that describe the additional resources inherent in visits for primary care and particular kinds of non-procedural specialized medical care. And then a new extended visit add-on code for level 2 through 4 visits to account for the additional resources required when practitioners need to spend additional time with their patients. So for level 2 through 5 visits, choice to document using the current framework, MDM or time. When time is used to document, practitioners will document the medical necessity of the visit and that the billing practitioner personally spent the required amount of time face-to-face with the patient. Typical CPT code time will be reported plus any additional extended prolonged time. When using the current framework or MDM to document for levels 2 through 4 visits, CMS will only require the supporting documentation currently associated with level 2 visits. So on this slide, you can see the time requirements and payments proposed for 99212 through 99214 at $90 and 99215 at $148. Next, you can see the expanded add-on code reimbursement rate at $157 for 99212 through 99214 plus the add-on code, and then 99215 plus the add-on code at $281. This next slide shows the current reimbursement rate for established office visits and the 2021 estimates. So for example, you have a 99213 currently reimbursed at $75.32, but in 2021, they're proposing to pay $90 or $103 for primary care or non-procedural care. And this last slide shows the current reimbursement rate for the new office visits and the 2021 estimates. So you can see here 99214 currently reimbursed at $166.86, and then for 2021 there'll be a base payment of $130 or $143 for primary care and non-procedural care. So after consideration of concerns raised by commenters in response to the proposed rule, CMS has decided not to finalize the following proposed changes. So reducing payment when EM office outpatient visits are furnished on the same day as procedures. They've decided not to establish separate coding and payment for EM visits in the podiatry specialty. And they've also decided not to standardize the allocation of practice expense RVUs for codes that describe those services. So now I want to take a moment to mention one of our newest tools on supercoder.com, which is EM Calculator. EM Calculator is a free tool for supercoder.com subscribers. Since EM coding is so complex, it just makes sense to use an automated EM calculator. So you'll find EM Calculator under the coding tools section of Supercoder, and I've highlighted here so you can see exactly where it's located. The free EM Calculator helps you to move quickly through the history, exam, and medical decision-making components for EM codes. If you're coding based on time, or if you need to report critical care services, this tool has tabs for that also. It even includes CMS, EM documentation guidelines, and tips to make EM coding more manageable. The result, you'll add order to the EM criteria chaos and feel more confidence in your EM code selection. You know that finding the right level of EM codes helps to ensure accurate reimbursement for the evaluation and management services that make up a large part of your organization's income. But don't forget that reporting the correct EM codes also supports accurate EM benchmarking and leads to less stressful audits. So now we'll move on to virtual care services. Telehealth services are at the intersection of many new policies. There's no denying that technology is a necessary element both in daily life and in healthcare. And as the industry keeps evolving while streamlining everyday medical processes, the feds and private payers alike are promoting new technologies that expand telehealth services to deliver more efficient care nationwide. In response to the calendar year 2018 Physician Fee Schedule proposed rule, CMS received feedback from stakeholders supportive of expanding access to services that utilize technological developments in healthcare. CMS is interested in recognizing changes in healthcare practice that incorporate innovation and technology in managing patients. CMS expects to increase access for Medicare beneficiaries to services that are routinely furnished via communication technology by clearly recognizing a discrete set of services that involve the use of communication technology. To support access to care using communication technology, CMS has finalized the following policies. So they're going to pay rural health clinics, or RHCs, and federally qualified health centers, FQHCs, for these virtual services outside of the rural health clinic. For calendar year 2019, CMS finalized payments for rural health clinics and federally qualified health centers for communication technology-based services and remote evaluation services that are furnished by an RHC or FQHC practitioner when there is no associated billable visit. So only if no other services are billed on that same data service. These services will be payable for medical discussions or remote evaluations of conditions not related to an RHC or FQHC service provided within the previous 7 days or within the next 24 hours or at the soonest available appointment. RHCs and FQHCs will be able to bill for these services using a newly created RHC FQHC Virtual Communication Service HCPC code G0071 with a rate set at $13.69, which is the average of the Physician Fee Schedule national non-facility payment rate for communication technology-based services and remote evaluation services. You will report this code when a rural health clinic or federally qualified health center spends 5 or more minutes with an RHC or FQHC patient in a non-face-to-face communication using a telephone or the internet, or when the provider remotely evaluates pictures or videos for the same type of patient in place of an office visit. The provider may get a brief history from the patient, review the patient's current list of medications, and make a medical decision-making regarding recommended treatment with a note to make an appointment if symptoms don't improve. The provider documents the specifics and the amount of time for the discussion in the patient's chart. To support access to care using communication technology, CMS has also finalized policies to pay clinicians for virtual check-ins or brief non-face-to-face assessments via communication technology, and also pay clinicians for remote evaluation of patient-submitted photos or recorded video. The final rule also expands Medicare telehealth services to include prolonged preventative services. They have implemented policies from the Bipartisan Budget Act of 2018 for telehealth services related to ESRD patients receiving home dialysis and beneficiaries with acute stroke, and implement Support for Patients and Communities Act policy to expand telehealth services for treatment of opioid use disorder and other substance use disorders. CMS is also implementing a provision from the Substance Use Disorder Prevention that promotes opioid recovery and treatment or support for Patients and Communities Act that removes the originating site geographic requirements and adds the home of an individual as a permissible originating site for telehealth services furnished for purposes of treatment of substance use disorder or a co-occurring mental health disorder for services furnished on or after July 1st, 2019. Additionally, the Support for Patients and Communities Act establishes a new Medicare category, benefit category for opioid use disorder treatment services furnished by opioid treatment programs, or OTP, under Medicare Part B, beginning on or after January 1st of 2020. So back in July of 2018, CMS proposed 2 HCPCS codes, GVCI1 and GRAS1 for virtual check-ins and remote evaluation of patient videos and images. According to the agency, those proposals were placeholders for the end codes, which will be paid separately and use communication technology for physician services. So here is an overview of the 2 finalized HCPCS code choices. G2012 for brief communication technology-based service, for example, a virtual check-in provided to an established patient, not originating from a related EM service provided within the previous 7 days, nor leading to an EM service or procedure within the next 24 hours or soonest available appointment, with 5 to 10 minutes of medical discussion. So this code was originally referred to as GVCI1 in the calendar year 2019 proposed fee schedule. G2010, remote evaluation of recorded video and or images submitted by an established patient. For example, your Store and Forward, and this code was originally referred to as the GRAS1 in the calendar year 2019 Medicare Physician Fee Schedule proposed rule. So the purpose for creating these virtual services code is to help physicians determine if an office visit or another service is necessary. Though they support more efficient care, these non-face-to-face codes come with a laundry list of documentation rules. So for example, the patient must be established, the service cannot lead to an E&M visit, and so on. These documentation rules aim to show medical necessity and are meant to curb overutilization. CMS notes in the Physician Fee Schedule guidance that it plans on monitoring providers' uses very closely for those codes. We also note some changes to interprofessional telephone internet services in the new year that were recently finalized with the 2019 Physician Fee Schedule as well. So the revisions focus mainly on the inclusion of electronic health record into the descriptor. Moreover, according to the final rule, these previously bundled codes will now be paid separately too. So CPT codes are as follows: 99446, 99447, 99448, and 99449 will all add electronic health record or EHR to the type of assessment and management service that can be reported with these codes. The addition reflects the widespread use and acceptance of the EHR in healthcare delivery. These codes are typically reported by a specialty physician who receives a written or verbal request from a physician or other qualified healthcare provider to offer an opinion on a case. So 99446, Interprofessional Telephone Internet Electronic Health Record Assessment and Management Service provided by a consultative physician, including a verbal and written report to the patient's treating or requesting physician or other qualified healthcare professional. 5 to 10 minutes of medical consultative discussion and review. For 99447, it's for 11 to 20 minutes of medical consultative review and discussion. 99448 is for 21 to 30 minutes, and 99449 is for 31 minutes or more of medical consultative discussion and review. Meanwhile, you can add the following two codes to your CPT checklist that primarily focus on a written report and referral service. So CPT 2019 adds 99451 to report 5 minutes or more of medical consultative time by a consulting physician, typically a specialty physician who receives a written or verbal request from a physician or other qualified healthcare provider to offer an opinion on a case. This code covers assessment and management services via telephone, internet, or electronic health record, and includes a written report to the requesting or referring provider. 99452 was also added to report 30 minutes of time spent on interprofessional telephone, internet, or electronic health record referral services by a requesting or treating provider, that is, a physician or other qualified healthcare professional who is providing a consultative physician report with background information regarding the patient's condition. So make note that the final policy will require the patient's verbal consent which must be noted in the medical record for each interprofessional consultation service code. Cost sharing will also apply for these services too, and the codes are applicable only to providers who can bill Medicare independently for EM services. So now that we've covered the EM and virtual care changes related to the final rule, I want to also mention some changes to MIPS for the Quality Improvement Program. So we're in the third year of the Quality Payment Program, QPP, which includes the Merit-Based Incentive Payment System, or MIPS. The QPP is connected to the Medicare Access and CHIP Authorization Act of 2015, or MACRA. Because MIPS may result in Medicare payment adjustments, understanding the changes is also essential. Regarding year 3 of MIPS, CMS has made changes to remove MIPS process-based quality measures that clinicians have said are low value or low priority in order to focus on meaningful measures that have a greater impact on health outcomes. The rule also will overhaul the MIPS Promoting Interoperability, formerly called Advancing Care Information Performance category, to support greater EHR, interoperability, and patient access to their health information, as well as to align this performance category for clinicians with the new Promoting Interoperability program for hospitals. For the Promoting Interoperability Performance category, CMS is requiring that MIPS-eligible clinicians use 2015 edition certified EHR technology beginning with the 2019 MIPS performing period. So this means that physician incentives are now directly tied to doctors updating their systems so that they are interoperable. 2019 also added new provider types that are now able to participate in MIPS. In addition to physicians, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and groups of such clinicians, these newly added providers include clinical psychologists, physical therapists, occupational therapists, speech-language pathologists, audiologists, and registered dietitians or nutrition professionals. CMS also introduced an opt-in policy so that certain clinicians who see a low volume of Medicare patients may still be able to participate in MIPS if they choose to do so. If the clinician chooses to opt in, be aware they will be subject to the MIPS performance requirements and payment adjustments. To be a part of the MIPS track of QPP, you need to exceed all 3 low volume criteria. Bill more than $90,000 per year in allowed charges for covered Medicare Physician Fee Schedule professional services, and provide covered professional services to more than 200 Medicare beneficiaries in a year, and furnish more than 200 covered Medicare Physician Fee Schedule professional services. The number of the service element is new for 2019. So if you don't exceed all 3 for 2019, you are excluded from participation. In addition, CMS is providing the option for clinicians who are based at the healthcare facility to use facility-based scoring to reduce the burden of having to report separately from their facility. In addition, the rule continues CMS's work to lower prescription drug costs. Effective January 1st of 2019, payment amounts for new drugs under Part B will be reduced, decreasing the amount that seniors have to pay out of pocket, especially for drugs with high launch costs. For the performance categories, a few changes have been made. For quality, CMS removed certain measures that, as a part of the Meaningful Measures Initiative, and shifted the small practice bonus that's worth 6 points from the final score calculation into that performance category. There were also 8 new episode measures added to the cost category. For facility-based quality and control measures, clinicians who are hospital-based can use their hospital's performance under the hospital value-based purchasing program for the MIPS quality and cost performance measures. Refinements were made to the improvements activity inventory. And the promoting interoperability category was overhauled to simplify, focus on interoperability, align clinician policies with hospital policies, reduce measures, and change scoring to be focused on performance. So since we've just discussed MIPS, MIPS Manager is a tool on supercoder.com that can help you with your MIPS and macro research. You'll be able to take the frustration out of finding information on macro and MIPS, quality measures, the cost category, improvement categories, and promoting interoperability. This user-friendly MIPS online tool gives you faster, easier access to the data you need about Medicare's merit-based incentive payment program. Maximize points and payments without getting confused or bogged down by time-consuming searches, and you can learn more at supercoder.com/MIPS Manager or speak with your account manager for more information on MIPS Manager. So just to do a little quick recap of what we've covered today, CMS initiated the Patients Over Paperwork Initiative to reduce administrative burden and promote patient-focused care. EM documentation requirements have changed for 2019, but the payments will not be affected until at least 2021. Virtual care expanded with new and revised codes. And note the changes to the quality payment program as well. So the resources for today's webinar are listed here. And I'd like to thank everyone for attending today's webinar. I hope that you've learned some helpful information and that you have a great day ahead. And please note also that the handouts are included in the handout section of the GoToWebinar. Thank you so much and have a great day ahead.
Thank you, Nikki, and thank you everyone for joining us today. Feel free to drop us an email with your suggestions and feedback. Thank you once again for joining us. Thank you.